Hello and welcome to Marburn's webinar titled Understanding and Addressing Anxiety in Children. Thank you for being with us. My name is Stephanie Royal and I am the Executive Director of the Marburn Education Collaborative. Our webinar this evening is led by Erin Fiorito and Dr. Rochelle Dunn. Experts in the area of anxiety, they are going to break down how anxiety can present and strategies to support children. So anxiety impacts up to 1 in 3 people, and those who learn differently are more likely to experience. Learning differences are at the core of Marburn's mission and who we serve. In our 42 years, we have built a program that celebrates students who learn differently and help them awaken their full potential. In our day school, our small class sizes, highly trained teachers, and intentional individualized approach makes this possible. If you would like to learn more about this program, we are offering an information session next Wednesday at April 10th at 8:15 a.m. And you can experience Marburn by seeing our classrooms in action. In our outreach work, we serve students and families in our greater Central Ohio community. We provide services such as the seminar, tutoring, free early reading screenings, and summer school to support students where they are. In a moment, I will introduce our speakers. First, just a few housekeeping items. You may leave your questions in the chat at any time, and the speakers will try to get to as many as possible during the presentation. At 7:45, we will conclude the seminar, and a quick survey will pop up for you to complete. We appreciate you taking just a minute to share your thoughts. And we will share out the presentation and recording of the webinar in a follow-up email. So on to our introductions. Dr. Rochelle Dunn is a practicing counselor and supervisor in the greater Columbus area. Dr. Dunn received her doctorate in counseling from The Ohio State University in 2004 and teaches graduate students at The Ohio State University and Liberty University. She has worked to help area school districts remove mental health barriers to academic achievement and has provided professional development to staff and parents. Dr. Dunn lives in Pataskala with her husband and 3 boys and currently runs a private practice in Pickerington, Ohio. And we are so fortunate to have her in Central Ohio as a resource in her expertise. Erin Fiorito is a licensed clinical counselor with experience working with children and families in a variety of mental health and academic settings. After receiving her master's degree at The Ohio State University, Erin worked as a community-based therapist and supervisor in the Columbus area, supporting at-risk youth and their families. Currently living in Cincinnati, Erin has supported students in the academic setting and supporting students with learning differences, ADHD, and executive function difficulties. Erin works as an expert consultant for evidence-based treatment program targeting troubled youth and has a private practice in Cincinnati. Erin is also a Marburn Board of Trustee member, and we are fortunate to have her expertise on the board. So thank you both for being here, and I will let you take it away.
Thank you so much, Stephanie. Appreciate that. We are so excited to be with you all tonight to talk about anxiety and depression with kiddos. So we're super excited about that, and we'll really invite your participation throughout because Erin and I have developed this webinar in the PowerPoint, but in reality, we want it to be helpful to each of you. So as we start talking, please do feel free to put those questions in the chat, or if it's too much to kind of type in there, feel free to raise your hand and ask the question as well, because we really want to make sure that this relates to what you need to get out of the disorder, okay? Or, oh my goodness, out of the presentation. So let's start. This is kind of where we can expect to go. We're going to start by talking about the current state of mental health issues. What do we see with adolescents today and kiddos? What do we notice about trends that are changing? And oh my goodness, even before the pandemic, but especially since, we see an explosion of anxiety-based issues with kids and adults. Then how can we coordinate with and find mental health providers? How do we do that successfully? And what do we know about the mental health system, particularly here in Central Ohio area? And then we'll touch on specific diagnoses as well. Okay, so hopefully that is the kind of information you're hoping to get from the presentation tonight. And again, I just want to say this, please do put your questions in the chat, and then also just raise your hand and let us know that you have something you would like to chime in on. So we do want some participation in this slide, so hopefully you'll be able to participate. But just when you think of someone who is struggling with mental health issues, kiddos in general, what immediately comes to your mind when you think of kids who are struggling? I'm going to give you just a minute to put some things in the chat or to share. Oftentimes what we'll hear are things like maybe the kiddo who's totally withdrawn from school, won't go to school at all, kids that are super anxious about doing anything outside of the house, anxious to try anything new, maybe having some behavioral disruptions as well. But we want to hear what comes to your mind.
You might also think about struggles with friends, making friends, keeping friends, those sorts of issues.
I think as you reflect on this, and I'm not sure if people can type in the chat or not, but as you, okay, yeah. As you reflect on this thought, many of you, when you were in school, kids who struggled with mental health disorders probably weren't in your classrooms. They might have been removed from school completely. Although some of you might be young enough to remember having kiddos in your class who are struggling, some of you definitely will not remember that experience. So curious, just if you can't put it in the chat, just really do want you to be thinking about what is the image of the kiddo that you have that comes up when you think of somebody struggling, because in 2024, we know that anybody can be struggling with mental health. They may be hiding it, they may be masking it, it might not be evident to you, but we know that absolutely anybody can be struggling. And I think that's the real image that we want people to understand, no matter what stereotyped picture we have in our heads about who struggles. Anybody could be struggling with mental health. And Stephanie shared that number, about 1 in 3 could be struggling with an anxiety-based disorder. That wasn't just adolescents and kiddos, that's adults, that's across the board. And honestly, I have seen some people cite up to 50% of people who meet criteria for an anxiety-based disorder. So it's beyond an epidemic, it's beyond an issue for us to think about and to really put our brains together to solve. So, good.
Okay. Just one thing really quickly. So the chat right now is disabled in this, and people are putting some comments in the Q&A. So I'm going to try to change that, but just so you're aware, there were some comments in there.
Oh, okay. So Jennifer, thank you. Your 16-year-old is very, very shy. I get that too. So just noticing maybe an inability or reluctance, one or the other. I don't want to put a value to that, but to really do new things or maybe engage with new people. Yes, thank you. Yeah. Okay. So we put up this hierarchy of needs, and I'll bet most of you remember this, but Maslow's hierarchy of needs. Notice that at the bottom of it, we have those physiological needs. So air, water, food, shelter, sleep, clothing, reproduction, all those physiological needs. Then we move up to safety needs. We move further up to love and belonging, then up to esteem, and then up to self-actualization, right? But the whole goal with understanding this hierarchy was that the lower level needs, so the needs at the base had to be met before anybody can move up. So we're not going to be able to think about self-actualization unless we feel safe. We're not going to be able to think about self-esteem or recognition unless we do have those love and belonging needs met first. So just a real important reminder that we have to have these really basic needs met before we can show any of these higher level, I don't know, emotional abilities. We really do. And you think about how often in schools kids will say they don't have safety needs met. I know at least 30% of kids say they missed one day in the last year because it didn't feel safe to go to school. And safety needs are a big deal with kids. I mean, many of you probably didn't do intruder drills when you were in school, but my goodness, when those practice sessions happen, there is so much anxiety present. And most of the schools that I've been in, when they do an intruder drill, it is just like flip a switch, let's get back to class. We're going to do math now. There's no processing, there's no talking about the fact that we were just all in a corner, just preparing in case an intruder came. So we really do have to think about how we set up an environment that can produce feelings of safety and also help the kids have their physiological needs met. Okay. I got sort of a reality check on that whole safety needs thing because my son, who was my oldest son, who really always did love school. That's not true for all of my kids, but he was the one who loved school. He told me once that he hated the drills. And I said, Frankie, that's interesting to me. Tell me why you hate the intruder drills. Well, because they expect us to go right back to class. And I said, don't they announce that it's a practice session and you're just going to practice it and go back and there's not a real intruder? He said, yeah, but I'm not really sure that they would tell us the truth that there was an intruder. And I thought, oh my goodness, you're right. You're right. So not only was he having his safety needs like pulled at from the perspective of practicing to have an intruder coming, but also the idea that maybe he didn't trust that they would be honest if there was a crisis happening anyway. So I really do just want us to remember this. We have so many great teachers and educators who do try to meet these needs here at the base, but we have a long way to go to reach all students, to help all students feel safe and help all students have their physiological needs met. Okay. And yet we won't get to those higher level points unless we do meet those earlier needs. So.
Are you ready for me to move on?
Yeah, please.
Yep.
I'm curious, and now we have the chat enabled. So thank goodness for that. Thank you, Stephanie. What do any of you think has caused a trend toward more people? We have adolescents, but we could have kiddos there, we could have adults there. What's caused a trend towards more people having increasing mental health needs? What do you all think? Uncertainty. Yes, good. Uncertainty, frankly, Laura, about just about everything. Not just safety, but future, how peers see them, all kinds of things. There's just so much uncertainty. Absolutely. Absolutely. What else? I'm just going to say it. I'm sure somebody's typing it right now, but many people will put up, there you go. Thank you, Lori. Many people will mention social media in this area, that we do speculate that social media has a real impact on people's self-esteem and their anxiety and everything about developing people, right? We really do think that. And now one of my areas of research now is around artificial intelligence and the impact of that on teenagers and their development. But beyond just thinking about social media, what Lori hit on there is the comparison that happens, right? And if you think about when kids get access to social media, I know the age limits that are out there. I do know that. But many kids get access to social media in middle school, right? And that happens to coincide with the same time that they start to develop perspective taking. And I can't tell you how unfortunate that is. Before a person has perspective taking, like a little kiddo, you see them at the grocery store, they have like striped sweater on, maybe a swimsuit bottom, maybe rain boots, like they are rocking their favorite outfit with little care in the world. And then they keep developing and their perspective taking kicks in, and all of a sudden they can know that other people have an opinion of their outfit. And right at that time, or right, they have an opinion of them, period, and an opinion of what they talk about and say and how they hold themselves. And right at that time, when perspective taking kicks in, now we are also exposing them to social media where, my goodness, I don't just have to worry about the other kiddos in my class. Now I have to worry about thousands of people online and what the impact of that would be. So comparison to others is really a big one. I know there's an old wives' tale that comparison is a thief of joy, and I can really see that for sure. Laura, you put political issues and world affairs for sure. Anything else that you guys can think of that really does seem to have us trending towards more mental health needs? Some people would say nutrition changes, sleep changes, right? Erin, any thoughts about that?
Yeah, I think I would just add, and this goes along with comparison, just the pressure to succeed, pressure to excel, pressure to perform. I have younger children, but just the amount of activities we have our kids involved in at younger ages, and asking them to do things that when I was 6, 7, 8, I wasn't doing. Just when it comes to performing in competition, I think those types of things could cause the trend. And the way we see it is, there's other families doing it. It's kind of this snowball effect. A lot of people are doing it. So if our kids aren't part of it, are they left out? So I think there's that pressure for everyone.
Yeah, for parents, for sure, right?
Yeah,
Yeah,
absolutely.
sure.
Yep.
Sometimes I'll say to my teenage clients, tell me one area of your life that you don't feel pressured to be the best in. And rarely can they identify an area that they're only engaging in for fun. If they're doing scouts, they have to be the Eagle Scout first. If they are doing dance, they have to be in competition dance or competition gymnastics or you name it, robotics, like you name it, they feel pressured to be the best in it. And I think that's a lot of weight because I would challenge any adult hearing this presentation to think about that for themselves. Like, do you feel pressure to be the best at everything in your life? I doubt it. Unless there's also a struggle there. I doubt you feel pressured to be the best in everything. And when we give our kids the impression that they have to be the best at everything, there's a really profound impact on kids. Right? It's a really profound impact. So I remember seeing how early parents were putting their kids into baseball, and not just baseball, but travel ball, of course, because who wants to fall behind? And then also extra tournaments and extra practice. And oh, if you can make it, we'll practice every day of the week. And I just remember thinking, like, we actually signed our little guy up for baseball, and we act like he has to love it. And at some point, would he feel like he could say to us, this is not my passion? I hope so, because he sure did. And my response to it was like, you're right. Like, if you're done with baseball and the season's done, then that's great. We'll just explore some other things and have fun with other talents as well. But we label, well, label's not the right word. We target our kids towards specific activities. We lock them in and they start to feel like they have to be perfect in those areas, perfect at school, the perfect kid, the perfect friend. So good. And if you'll let me, I just want to say something about this as well, since we brought up social media before. That when I say perfect friend, I don't just mean, oh my goodness, I'm perfectly nice to you on the playground. For teenagers today, being the perfect friend means being available 24/7. Part of the anxiety that kiddos have about losing their phone comes from being available to their friends who are having mental health struggles. And if you have a kid melting down because they've lost their phone, I like 95% of the time, I will guarantee you that they are offering emotional support to their friends online. And there's an immense amount of pressure that they feel to be present if their friend feels like they're going to cut, or if their friend is having suicidal ideation. Your child, our children, feel pressure to be available to offer support for that kid, to be a good friend, right? Sometimes I'll talk about that with kids and say, mental health professionals don't even do that. Like, mental health professionals are not available 24/7. And there's this thing called on call. And if a mental health professional is on call, they get paid for it. And there's a reason they get paid for it, because it's hard and it's taxing work, and it's a lot to expect of somebody who's also managing a life, which they are. So I just want us to pay attention to that, because I definitely see that impacting kids' mental health needs as well. So good. Some of the current level of need that we want to explore, just know that there's an estimated $247 billion dollars spent each year on childhood mental health disorders. That amount of money is way more than 247 billion at this point, but that was the latest number that we could get from a reputable source. In 2021, more than 4 in 10, so about 42% of students felt persistently sad or hopeless, and nearly 1/3 experienced poor mental health. Right? That's a lot. 42% is a lot to feel persistently sad or hopeless. And I think all of us would like to think now in 2024, we've rebounded from the pandemic and people might be feeling more hopeful, and some are. Some are, but for sure some aren't, and we don't want to leave them behind. About 5% of children and adolescents have extreme impairment in their ability to function from mental health needs. So 5% is a lot. That is a lot of potential, a lot of creativity, a lot of you name it to lose from our world. So we have to really, I don't know, target resources to addressing this. So. Some other statistics, only 50% of children with mental health disorders receive treatment for their disorder within the past year. I'm not sure if we have this on a later slide, but the Center for Disease Control shared that from the onset of anxiety symptoms to consistent treatment, it's about 7 years. So kids will talk about, and parents will talk about, well, they started exhibiting some of these symptoms, but it was about 7 years before they started to receive consistent treatment. So pretty big gap there, especially when you think about the need that we see. Children with anxiety-based disorders were least likely to have received treatment. Okay. I think there are a lot of factors that go into that as we see increasing numbers of anxiety, I think people start to accept it as just part of the human condition. I think parents start to see a little bit less urgency to getting help unless it's really urgent, which makes me sad. But I think that's kind of the area that we're in. And then also, just so we're on the same page, it is hard to get treatment for somebody. It's not like I need to make an appointment. I call somebody and I get an appointment. Many times people will talk about calling over a dozen providers before they're able to find one that is able to schedule an appointment, which might be a few months out or a few weeks. And then we're at the point where we're deciding if it's a good fit. So then if it's not a good fit, then we're going to have to start that whole process over again. So it really is challenging to get help. So there's a lot of parents who do want to seek out treatment, who really feel the barriers that are present in that system. And then in 2021, more than 1 in 5 students seriously considered attempting suicide, and 1 in 10 students did report attempting suicide. Okay. So a lot of kiddos that are in the position now of thinking about suicidality and suicidal ideation, which, I mean, that's a whole new level of concern. So we're talking about over 20% of kids seriously considering suicide as an option. But I just hesitate and take a moment to say this to you. All of you I know are here because you have kids in your life. And because we do have such an issue with suicide, I really do just really implore you to have a conversation with your kids about that. They know the word. It's not going to be new to them. You're not going to be putting ideas in their head. You don't have to give a ton of detail, but believe me, they know the word. And it's really important for us to say to kids that if they're feeling down more than a day or two in a row, they need to tell you so you can have at least a shot at helping them. Don't let them do something without you ever knowing about it and without you having a conversation about it. We see a real increase in kiddos who are impulsive, who are completing suicide, which to me is really heartbreaking, because I just envision as a parent feeling like so hopeless and really just desperately wishing I had had a chance to help them. And when it's done impulsively, that chance is not often there. So I do just want to respond to this. How would you recommend balancing keeping your child involved in activities and trying new things? I think saying we want to keep one or two of the old activities, but we always want to be trying new activities as well. So if you're able to do some of the activities that are offered on the weekend, maybe just like a 2 hour stint, let them give it a shot and see if they're willing to give it a go, or if they're even interested in it. I don't know why this example popped into my head, but if they're interested in horse riding, find an open house at a barn and let them go and see if it feels like a good fit for them. Interacting with animals for kiddos who are neurodivergent is fantastic. So I guess maybe that is why it popped in my mind, but any activity like that, like I know that some of the communities offer golf camps in the summer, like doing something like that when the stakes are low, people are learning and they can just see if it feels like something they would want to pursue. Yeah, that's a great question. It is hard. I don't ever want to sound like I'm like poo-pooing parents or talking down to parents. I never want to do that, because I'm also a parent. Erin's a parent. We balance those same challenges, like trying to keep what you said, Erin. Everybody's doing it. So you want
Yeah.
them to have a shot. You want them to stay on track if they're really interested in it later on. So I do understand those challenges. And I remember, well, I still have it because I have a 14-year-old. So
Yeah.
so we noticed some real changes around diagnoses over the last probably 7 to 10 years. And one of those changes has to do with comorbid diagnoses. I can tell you very frankly, I do remember working with kids early in my career, so the end of the 90s, that had one diagnosis. Literally, that's it. One thing that they needed to work on and resolve, one diagnosis. And now it's pretty rare, for me at least, to get somebody with just one struggle. So about 40% of people have a comorbid diagnosis, excuse me. And I'm certain that that's higher than that now. So we really do notice that trend. When you look at anxiety and then also folks who are on the spectrum, about 85% of people who would identify as being autistic also have an anxiety-based disorder. Okay. And then look at that quote below that. 45% of children with one or more emotional, behavioral, or developmental condition also had a learning disability, as compared to 2.7% of children without these conditions. So think about that. There's such a connection. The longer I practice and reflect on what I see, what I'm really just certain of is that everything is so connected, right? We've created these arbitrary categories, and I'll just use these examples: anxiety, depression, autism disorders, ADHD. And if we took those pages out of the DSM and we line them up, we could look at the criteria and be like, oh, same, 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 same. We could just like literally go across and notice how many of the diagnostic criterion are the same for each of the disorders. I'm just so believe that these disorders are way more connected than we realize, that yes, we have created these arbitrary categories, but it really doesn't fit well for many people, which is why I think we see so many of those diagnoses happening in groups now. Do you have any thoughts about that, Erin?
I don't have thoughts about that. I think that just adds to why this is also complicated, because
Yeah.
it's sometimes hard to determine, at least for me, like where to start with a family. For the family, it's hard to determine where to start, what came first. So I think it just speaks to that complexity everyone is seeing.
I so agree with that. And like, what's the primary diagnosis, right? If we would identify one as being primary.
Yep.
There's an approach in counseling called solution-focused approach. And I love solution-focused approaches to counseling, but essentially one of the tenets is that we don't have to solve the big picture. We don't have to tease everything out for a kiddo or for a patient client. We just have to make a small change. And one small change can affect like the big picture. It can make big rippling effects on the person's life. And I am so thankful for that, because if we had to really figure out what was going on in every scenario with every client, we would not get anybody help. So I'm just thankful that we can make these small changes. And I think when you are working with a clinician, it's really important for you to feel like you are problem solving with them, with the kid, with the parents, with the clinician, everybody together as a team, that you're engaging as a problem solver, because that is what will help kids move towards being better, feeling better, thinking better, the whole gamut. Okay. So, because we really do have complicated pictures right now with regards to diagnoses. Medication implications, obviously, there are so many medication implications. If we have lots of diagnoses, what do we treat first? That does turn out to be a big deal with regards to ADHD and anxiety. When you think about how anxiety presents in your body and how it affects you, when you have any elevation in heart rate or metabolism or energy or anything, like any sort of elevated regulation, your body's going to interpret that as anxiety, right? Because we have an anxiety issue. Well, much of the treatment for ADHD, at least from a medicine standpoint, is a stimulant. So what's going to happen then if my real issue is anxiety? We already said the criterion are so similar across the board. So what happens if the kiddo has anxiety and ADHD, and I treat ADHD with a stimulant before I've ever addressed the anxiety? I am really going to cause a crisis with this person's anxiety, this kiddo's anxiety. And that's becoming more and more like present in people's thinking. Most psychiatrists now, most family physicians now will treat anxiety first, thank goodness, because we had a period of time there where a lot of people were hospitalized because of that. So really important when you're thinking about medication to work with somebody who does just know all the ins and outs. And we're lucky in Columbus to have lots of child-based psychiatrists here. That's not the case around the country. If you think about I don't know, what is it, like 20 million? And this is an old number, so it's way more than that now, but like around 20 million kids and adolescents who are diagnosed with something, and 7,000 psychiatrists trained to treat children and adolescents. So I'm just going to do that math real quick, because probably some of you can do it in your head, but I can't. So if we did that, that would be almost 3,000 patients per psychiatrist. So we don't have enough. We're lucky in Columbus, Ohio to have a number, and we still struggle to get in to see folks for medicine. And yet there are other places in the country where they struggle a lot more than we do here. Important to engage in the differential diagnosis process, which is what Erin and I were just talking about, in terms of figuring out what's primary, what we need to address first. And then again, remember what I said, how lucky we are that we can make small changes that will have big ripple effects. We are incredibly lucky for that. So, okay. Don't forget, we're just encouraging you to continue to put your thoughts and questions in the chat, because we really do want to tailor this to your needs. Then I think the challenge that we are going to talk about with ADHD, I think I just jumped the gun on that, didn't I, Erin, and talked about it up above. So
A little bit, yeah. I think we
yeah,
could.
really do remember that. We try to address anxiety as the primary if ADHD is also happening, so we're not stimulating them into an anxiety issue. So
Yep.
hopefully that makes sense what I'm saying about that, because while there are non-stimulant options for ADHD treatment, still the majority of people think that best outcomes come from those stimulant-based medicines. So, all right. We wanted to talk a minute about levels of care, because it does stand out to us when we interact with parents that often people do not understand level of care. Something we don't have on here, because it would kind of be another overlay, is that we're going to work through the levels of care, but we also understand that many of these levels of care now occur in person and also via telehealth. Okay. So if we're at the most restrictive level of care, that would be residential. That would be the kiddo, the adult is removed from society, they're residential, that's for their safety and perhaps other people's safety while they receive that treatment. Okay. Erin, you might have had, just because of your expertise, you might have had a lot more people placed in residential care than I have had. So
Yeah.
what kind of outcomes do you see when those folks come back home?
So the youth that I've worked with that have been placed in residential are primarily placed there for what we would just call externalizing behaviors. So kind of disruptive behavior, things you would see as more obvious. They're acting out pretty aggressively in a lot of ways. And I think the sad thing for me about residential is that I don't find it to be as effective as some other types of treatment that might be out there for a lot of different reasons. Typically, youth that I've worked with will do well in the facility. And then when they return from the facility, oftentimes many of the stressors or triggers or environmental factors that were there prior to their stay remain. And I see a lot of kids kind of slip back into old habits.
Yeah.
So residential for me is, the kind of last resort often because there's the other levels of care really, I think we can do a lot of great work in those levels of care.
Yeah. For me, and I don't know if you're the same, but I mostly see residential as a holding pattern for safety. Because of what you mentioned, when the person returns home, that regression is great.
Yes.
And
Usually.
pretty quick.
Yep. It is
And-
quick, unfortunately.
Yeah. In 25 years, I can honestly say to you, I had one person go into residential treatment and come back improved, and it was sustained.
Okay.
One time.
Well, I guess that's better than zero.
It is better than zero. But I can tell you that the reason that they access that care is the dad was a professional football player.
Okay. So they
Yeah,
could afford
and I didn't even write, like, I know what the resource was just because it always stood out for me, but the utility of it was just basically nil for any other family because of the cost. So, but that is the most restrictive level of care. The next level that we would see is hospitalization. Obviously, hospitalization is reserved for people who are harmed to themselves or harmed to others. Typically, hospitalization is about 24, somewhere between 48, I wouldn't say 24, so maybe like between 48 and 72 hours. And again, remember I said it's for safety, so of like freedom from harm for themselves and for other people. And the reason people are removed from the hospital so quickly is that research studies show the risk factors for suicide decrease greatly after 72 hours, somewhere between 48 and 72 hours. It literally just falls off. It's almost like you see something falling off a cliff. It just goes straight down. So really quickly, kiddos who've been in the hospital for really significant self-injury or ideation are home. Now, sometimes you will see people hospitalized for longer. Sometimes you'll see them hospitalized for a week, 2 weeks. And typically what's happening there is they're adjusting medicine. So it's not just about keeping them safe and addressing the ideation, but it's also about getting them regulated on medicine. Once in a while, I see them stay in the hospital because there's not a safe place to discharge them to. But typically it's either the ideation, the risk factors have been removed and dealt with, and or they are adjusting to medicine. Now, I want to say something to you. Most of you are parents, right? And this is a really hard thing that I see parents go through. There's not a harder thing outside of losing a kiddo to suicide or just losing them, period, to deal with than knowing that your kid's a risk for suicide. And it's very challenging and difficult for parents to feel safe when those kiddos come home, especially when they come home so quickly. So I spend a lot of time with teachers telling me how hard it is to have students right back in their classroom, which I get. They feel uncertain about how to interact with the kiddo. They feel uncertain about how to support the kiddo. Totally understand that. But then in the back of my mind, I'm always thinking, and you have no idea how hard that is for the parent. So when if your kiddo is ever hospitalized, keep in mind they have to be discharged to somebody's treatment. And you should have a very quick appointment to set up some safety structures in place for you at home. They'll do a safety plan at the hospital, but you need to reiterate that with the clinician that's going to be providing ongoing care. And you need to have some really hard conversations with your kiddo about how long it will take you to feel secure that they're safe, and how long it will take you to get back to kind of being even keel, because that is a very challenging for our parents, very. So we've talked about residential, then we've talked about hospitalization. When you come down the continuum, then we have partial hospitalization, not used a ton for adolescents. We didn't put that on this chart. Mostly you would see them go to IOP or intensive outpatient. That's 3 meetings a week, about 3 hours. Children's Hospital offers it. Sun Behavioral Health offers it. Dublin Hospital offers it for adolescents. So we have a number of providers who do IOP treatments for adolescents and kids. And again, about 3 hours a week, 3 times a week. Really challenging for kids to maintain coursework when they're going through IOP. Really challenging. It can happen. I've seen it happen. And then community-based support. So there are some treatment options where well, Erin, this is your area of expertise. So
Yeah, it is really what that refers to. And you guys have a great, I live in Cincinnati, but there's a lot of nice options in Columbus through several different agencies that offer community-based services, but similar to IOP in the sense that it's intensive, maybe multiple times a week. In those services, you might get family therapy, might be individual with your child, but it's a more intensive treatment. So you're seeing your provider several times a week as needed to treat the things that are happening.
yeah.
In your home environment, like it is not in an office-based setting.
I did mention to you guys that many of these are provided via telehealth. So there's a new big tech company. I don't know if any of you have interacted with them, but it's called Charlie Health. And they're actually piloting something called extended outpatient treatment, so EOT, where it's just another step down of care. Instead of 3 3-hour groups, you do 2 2-hour groups, which I think is kind of interesting.
It
And
is.
then, yeah, it is. And then the least restrictive level of care would be that outpatient treatment. So going to an office, a home, or the clinician coming to the school to meet with the kiddo and provide treatment there. Most providers now meet with their clients every other week. There's such a need. It's very hard to meet with folks weekly unless there's a history of a significant crisis and or they're experiencing a crisis right then. So just keep that in mind. That outpatient treatment is likely going to be every other week pretty quickly. For me, what I do when I'm getting to know somebody, I meet with them every week for a couple of weeks, and then really quickly we go to the every other week format. Not just because scheduling like kind of dictates that, but also because I concretely want them to be practicing their skills. And a lot of times, if you're meeting every week, it's hard for them to report back how many times they had to practice, where 2 weeks gives them a significant amount of time. The wait time, I kind of alluded to this earlier, but just keep in mind, like the wait time right now can be significant. We do have a lot of providers, like our market here is pretty saturated. So there are a lot of providers in this area. So you'll be able to find somebody. The question is, if you go to somebody that's referred to, you might have to wait a little bit. Okay. And it just depends on who you connect with. So we do have a lot of great education programs in Ohio and access to providers.
We have a question in the chat.
Yeah. Okay, so I'll be honest with you, Laura. I think the skills that are learned in counseling should not be kept from the counselor or from the parents. And that's not confidential information. That's not your child's deepest, darkest secrets. I think that information should be shared. And just to make sure we're on the same page. In the first meeting, I meet with the parents and the kids, and I say, like, I'm only here as long as your parents invite me in. Like, your parents are your people. So there are certain things that we cannot keep from your parents. Like your feelings about them taking your phone away, we don't have to share that. You're being upset, like, about, I don't know, maybe changing bodies and things like that. We don't necessarily have to share that. But if we're working on skills together, if we're going to work together to decide how we can communicate that with the parents, so you can have some input, but I'm only here like for a limited period of time. Erin would only be here for a limited period of time. The parents really have to be the ones to help reinforce and support those skills. I don't like, I know this might be controversial to say, and I'm sorry about that, but I don't like this setup where I do want kids to have a safe place to talk and vent and process. I absolutely do. I'm passionate about working with them, but I don't like this setup where everything's secret from the parents. Because you all can support what's happening in counseling. You just can. And you know way more about your kid than the clinician ever is going to know. So I think really, if you don't feel like you know what the skills are, just asking to go into a session and having a conversation like, what's a way that I could know some of the skills so I could support them? I think that's what I would do. Because you're not invading anybody's privacy. You're not asking again, like the deepest, darkest struggles that they have. Just like, hey, when there's a skill that you're working on, please let me help support that. Okay, good. That was a great question. Great question.
All right.
Right. So moving into anxiety, you all take a
Yep.
deep breath.
Practice
So
the coping skill.
yeah, that's right.
It
So
is.
some of the common diagnoses we're going to talk about, we'll probably pepper in some of the others, but we're going to talk about social anxiety. And somebody mentioned their kiddo being very, very shy. So that's great. Great that we're going to talk about it. Generalized anxiety and then separation anxiety. And we might touch on phobias too. I probably will have a little bit to say about obsessive compulsive disorder as well. So, but please chime in and ask questions about anything that pops up in terms of questions and thoughts that you have. The overall way that anxiety presents, and that you're going to notice that school refusal and truancy. My goodness, I can't tell you how often schools will contact me and say, so we got this kid. They won't get out of the car. So, and sometimes it's the school counselor, he'll say, my principal wants me to go out and actually usher the kid from the car to the school. So that school refusal, being unable to get into the school building, is one of the first ways that we see anxiety present. Okay. Reluctance to engage in chores or assignments. Okay. Somebody said in the chat about perfectionism being an issue. I actually think some of what we interpret as obstinance and lack of minding, I guess is the word we used to use, their parents, is anxiety about not doing it right. I see that a lot. Or being worried about perfectionism. Nonetheless, you'll see a real reluctance to engage in chores and assignments. Sometimes what kids will say to me is this: I can't do it right anyway. I clean my room and I'm just going to be told that it's wrong. Right? So that does trigger perfection issues, and it also really does trigger anxiety. The next presentation is being hyper focused on body and changes. Sensing every change in their body. Oh, I had a twinge in my stomach. Think I'm gonna puke. My head hurts. Oh my gosh, do you feel that? Like, my skin feels so weird. Does your skin feel weird? They're super tuned in to what's going on in their body and their changes. I always say, like in trainings, nurses know who's struggling with anxiety in a school before anybody else does. School nurses always know, because those kiddos are down in the office saying they're going to puke, they're going to throw up, they're going to, you fill in the blank. They're very focused on their body and their change and the changes that they feel. And you'll start to hear that. You'll start to hear them perseverate on, am I going to throw up? Are you sick? Is that going to make me sick? I do think I had a headache. So if you start to hear that, you'll know that's related to their anxiety. The real resistance to being redirected from what they're thinking about. like their comfort, even though thinking about it is amping up their anxiety, it's more comforting to think about it than to not think about it. Okay. And then removing themselves from everything. That happened during the pandemic, but frankly, I have noticed it happening on a continuing basis. My bed is my safest place. It's the most comfortable place, right? I watch my shows in it, I do my homework in it. I just come home from school and I get in bed. Oh my goodness. By the way, that sounds wonderful. I mean, it does kind of sound wonderful, but it's not great if you're struggling from anxiety and you're using that as a coping mechanism. Now, very gingerly, I want to say something to you all. Many times when I meet a new client who's struggling with anxiety and they're an adolescent or a teen, what I need to know is, are the parents struggling with anxiety? Okay. That's a really frank conversation or maybe just reflection that we need to have. Because if we as parents are struggling with anxiety, we are absolutely going to impact our kids as they address their struggle with anxiety. We absolutely are. Remember when you took your kid home from the hospital and they said, remember, if baby's anxious, you'll be anxious. Remember, that's a thing. Make sure you're calm. That never goes away, but we don't talk about it. We're all co-regulated. So if there's a particular energy in the room, we meet it, right? We meet that. So for example, this is kind of a silly example, but let's say you walked into my office and Erin and I were in here and we were whispering. We're just kind of talking like this. You would come in and you would be like, hey guys, what's going on? And we would talk like that for a couple minutes and then all of a sudden you'd be like, why are we whispering? And the reason for that is we're co-regulated. Humans mirror other humans' energy, their tone, everything about them, we mirror each other. So if anxiety is a struggle for you, and I think we have this later in the presentation, but I just want to say this here. If anxiety is a struggle for you and you've noticed some of these factors being an issue for your kiddos, make sure that you're also getting help. There's no shame in having anxiety, no shame in that. But it would be a shame if you didn't get help, because that would be the first step to helping your kiddos. And because you can have really good outcomes really quickly. Addressing anxiety doesn't have to be something that spans years. Excuse me, it doesn't have to take a very long time. It can be something that you address really quickly and move on. And your kids, you will have a higher quality of life, and so will your kiddos, for sure. So, okay.
Okay. We'll spend a little more time on that topic too at the end.
Yeah, good. Okay. Remember, and this is kind of hard for kids to wrap their mind around sometimes because they're such concrete thinkers, and most of them think anxiety is bad. And I'm always saying to them, well, anxiety is not bad, right? Too much anxiety is bad, but anxiety is not bad. This is such an old model. Think about this. Sometimes I wonder, like, we think we have troubles in 2024. Like they really had anxiety in 1908. Like you could have been a child in a factory trying to just survive every day. Like that's anxiety, my friend. They had every illness then could have been a pandemic, right? So they were thinking about anxiety and also developing models then. So we know that some anxiety is very helpful. It stimulates us to respond to a situation that's not safe. It helps us prepare for situations that we need to prepare for. It's just that there's this level. You see where the level of performance is here on the left-hand side. You get to an optimal point with anxiety, and then that function, that helpfulness of anxiety starts to decrease really rapidly. So we do know that it can be helpful. We just have to capture that middle spot where it motivates us instead of stopping us in our tracks. Okay. But it is important for people to understand we're never getting rid of anxiety altogether, and that's not even the goal. It's not. Anxiety is what causes you to get a partner when you walk to the OSU garage at night, right? That's helpful. Anxiety is what makes you not walk behind a swing set when somebody's swinging. Like that's a very functional to have anxiety, and it's helpful. We just can't let it get to a point where it stops us. Okay. But really, look at that number, 1908. Isn't that interesting? That's just so curious to me. They were thinking enough about anxiety then that they had models developed to understand it and to address it. And that is really curious. I really wish I could just interview people from that time and be like, just let us learn from your experience with anxiety, right? Because that probably would have been like a more city-based thing. Because in the country, likely they weren't thinking about anxiety as much. It was just like, we're going to work on the farm, we're going to work in the store, we're going to do what our parents did and just like live our life. So anyway, I won't get off the track on that.
It is interesting.
It is so curious.
Yeah.
So then if we understand that anxiety can be very normal, and it is very normal, then it's really helpful for parents to see like, well then, so how do I distinguish a normal amount of anxiety from a pathological or a dysfunctional amount of anxiety? Number one, what is your child worried about? And is it something a child of this age should be worried about? Okay. So the biggest example that comes to my mind with this is an 8-year-old really worried and perseverating about death. Not necessarily normal for a kid of that age to be worried about dying, right? So really ask yourself, is this something that a person of this age should be worried about? That's the first question. Is the degree of distress realistic or unrealistic? Which one? Right? If they're not going to school, if they're totally withdrawing from friends, we would say that's not realistic. That's not helpful. It's not functional. Okay. So we think about what they're worried about. We think about the intensity or degree that they're worried about that thing. And then impairment. Does the distress interfere with their daily life? Are they unable to make friends? So that's social functioning. Are they unable to try new activities? Are they unable to order for themselves? Ding, ding, ding. That's a big one. Parents just order for kids all the time. Are they unable to fill in the blank? But all that social functioning, does that anxiety interfere with the kiddo's daily life? Academic functioning, is it causing them to fail classes? But beyond that, is it causing them to withdraw from classes that they should be excelling at? Is it causing them to not complete homework because they're worried about it not being perfect? Are they worried about answering questions or asking questions in class because of the anxiety, right? Then family functioning. Their anxiety and worry, is it creating conflicts at home? Is it limiting family choice? Do we not go to certain restaurants because we know that it's a trigger for the kiddo? Do we not ask them to go to the grocery store with us because that will be too much of a problem? Believe me, I understand that in some cases. I really do, because we're not trying to trigger the kiddo, but we should be working towards helping them be able to do normal functioning things as well. Okay. With regard to that family functioning, right now is a very particular time of year for my practice. I almost always get a few senior boys who come in who are incredibly anxious about the college process. They're not on the ball like the senior girls are. Believe me, I have had 3 boys. I hear of these senior girls doing all these things for college, and I'm just like, oh, that's really awesome. Good for you. They're not. Remember, their brains are like biologically 3 years behind the girls' brain. So I get these senior boys every year. They're anxious about school. They're college, I mean, they're withdrawing from the process. So they're not on the ball with the emails and the housing and everything that goes along with it. And then their parents, typically the mom, is super anxious about it. So all they're doing is fighting, right? Mom's bringing it up, the kid's avoiding it. Mom's getting mad, the kid's slamming the door and going in their room. That's all you talk about. It's really interesting to me because it does create conflicts. And right now at this time of year, it's a very particular conflict. So, and then the last question that we're going to ask ourselves is, when your kiddo gets anxious, how quickly are they able to recover? Okay, that's the real thing from a biofeedback perspective that you look at. Your heart rate elevates very quickly. Your blood pressure changes very quickly. How quickly can you, kiddo, adult, bring that back to normal? How quickly do you recover? Okay, because it's not the real quick stimulation of that that's going to cause an anxiety problem. It's the inability to use breathing and self-regulation techniques to come back to that normal state, right? It is kind of unfortunate. Oh my goodness. Okay, let's go. I'll stop talking.
Okay.
Thank you for the time check. Some more about the presentation. Then we did mention that anxious adolescents listen to their bodies too much. So do expect to see those physical symptoms first, those headaches, upset stomach or nauseousness, increased heart rate, constant need for the bathroom. And I do mean that constant need for the bathroom. Then followed by those cognitive symptoms, the avoidance of situations, overthinking. Sometimes it'll take a while before the kiddo shares with you that they're overthinking. That really just looks like they've withdrawn, right? Because they're in their head and did I say something weird? When everybody laughed, were they laughing at me? But they don't really make it a discussion oftentimes. And then cognitive distortions or persistent worry. So good. I'm sorry, I could talk about this all night long. Keep in mind that except in rare situations, avoiding a situation does not help decrease anxiety long term. There might be reasons why you avoid a situation at the beginning as you're engaging in treatment, but you shouldn't avoid it long term. Now, just caveat to that, fearful of heights, you literally could avoid that most of your life. Fearful of roller coasters, have at it. Don't really have to tackle that fear unless you really want to ride a roller coaster. But fearful of talking in front of groups, and I want to be a marketing professional, going to have to address that, right? So avoiding those situations, avoiding that presentation as a high schooler probably can't be our long-term situation. Sadly, right now I have a client and I'm just really reflecting on the disservice that might have been done. She never had to do a presentation in high school. It started off in freshman year. She was just struggling with it so much. She just never had to do a presentation. And now in college, she does as a freshman. And that I'm really reflecting on that and wishing that there had been a push maybe junior and senior year for her to at least to do one a year. Because now as a college student, she's doing that for the first time ever. So that's tough. So except in those rare situations, we're not going to avoid it long term.
Well, and just know also too, if you have a kiddo who is anxious, that avoiding things is a very common tactic of people with anxiety. So that'll be kind of that natural thing that they want to do and you know are hoping to do. So I think as the parent, sometimes we have to really push through that with them.
Yeah, my goodness, me too, right? I assume we're all like that. I hope I'm not like just odd. If I'm anxious about something, that's the last thing I want to do.
Of course,
So,
yep.
yeah. Social anxiety, about 5% of adolescents struggle with this diagnosis. I need to like look this up because I bet it's up around 25% at this point in time. Onset is about 13. So remember what I said about those perspective taking skills kicking in. So there we go, bingo. And then it's really just if we summarize the criteria, persistent fear of being scrutinized and or humiliated by others, right? And not humiliated like necessarily in an overt way, although that could be part of it. There could be like you're going to make fun of me, you're going to put something on social media. So it could be in an overt way, but it also is humiliated in a like, you're thinking about me like I'm dumb, or you're thinking about me like I'm weird. That's also humiliating. Okay.
Like the kids that may not want to get up and go to the bathroom during class, or they're afraid
Yeah.
to speak up or even raise their hand or be noticed in the classroom. Like these are
Absolutely.
those are more of the passive ways you may see this.
Yeah.
So there's more about that. Yeah.
Yep. You're going to get this PowerPoint too. So we'll move kind of quickly through some of these, but some of the ways that it presents: intense anxiety if called upon in class, fearful that they'll say the wrong thing, frequent worry that they're being judged, isolating socially, so withdrawing to their room, probably not going to the football games or basketball games or fill in the blank, right? Maybe homecoming or prom. Intense worry about an upcoming social event that might be a long ways off, goes out of the way to be invisible. My goodness, the mask. After the risk was gone, I literally had a client this week who stopped wearing the mask. There was no health risk, no impaired immune system in this week. And she would very vocally said, it's a way for me not to be noticed. So go out of their way to be invisible. And then being fearful of saying or doing something that others will think is stupid. Social media has really amped up social anxiety because these kids have seen people humiliated online. They have seen people tortured online with people making fun of them, ridiculing them. So, I mean, it is a real fear that people are going to think that you're stupid or you've done something dumb, for sure. Then we have generalized anxiety disorder, characterized by chronic excessive worry in a number of areas. These are those kiddos often that are perfectionistic and constantly seeking reassurance from adults. Worry is most often present and not limited to a specific situation. Really tough too, because maybe I'm a swimmer and I've swam since I was 11, and all of a sudden when I get in the pool, I'm having panic attacks. Well, I love to swim. Like, why am I having panic attacks now? I don't have anxiety. Okay, well, sometimes our bodies let us know we have anxiety when our brains don't recognize it, right? So free-floating anxiety are feelings of dread. That free-floating anxiety is just meant to indicate that you have a general anxiety that you walk around with, and it lands on different things, and it finds different things to land on. Right? So maybe today I'm worried about this presentation tonight, and maybe tomorrow I'm worried about, I don't know, fill in the blank, but it's always with me. I'm always worried about something. And you'll hear people say, it feels weird. I don't know what I'm supposed to worry about. Like that's a real interesting comment to hear. It feels like I'm supposed to be worried about something, but I'm not sure what it is. That's generalized anxiety. Okay. We can go on there. Yep.
Yep.
Separation anxiety, excessive fear when separated from home or attachment figures. Hey, you all, this used to present between ages 5 and 8. And now we see it way into teenage years. Right? So no longer can we say separation anxiety is just launching to school. A lot of people who are adults will say, when I was in 2nd grade, I cried for the whole first month. Now we see that happening with 16-year-olds, 18-year-olds, a real separation anxiety. And by the way, I see it on the parent side too, right? I had a parent say, my kid's got to come home from school. I'm worried about her too much. It's like, oh my goodness, okay. So no more Western Kentucky because you're worried about her too much. That's a real sign that there should be some intervention. These separation anxiety issues, I just want to mention, obviously it is an anxiety-based disorder, but a lot of connection here to trauma. If a kiddo has been exposed to situations of domestic violence, that can trigger a lot of separation anxiety, or, and this is very important, if they're just worried about their parents' health. Maybe parents have gone through a health scare. Maybe something happened while they're at school, like the parent had a accident. That can really trigger a separation anxiety as well. And we no longer talk about this, again, just being in those younger years. You can absolutely see it later on. Okay. All social anxiety, separation anxiety, generalized anxiety, all of those can trigger panic attacks. What does that look like in a child? Well, first of all, I want you to understand that children are not going to know that they're anxious. Sometimes adults don't know that they're anxious. About 96% of adults who have their first panic attack go to the hospital because they think they're having a heart attack. That's the absolute right thing to do because it does restrict your breathing. It does feel like pain in your chest. You should rule out a heart attack. But then you start to realize that, oh my goodness, that was my first panic attack and I didn't know what it felt like. So we know that anxiety and panic does not feel like what we expect it to feel like. So when we say to kids, what are you anxious about? Please don't expect them to be able to say that. There's no way they're going to be able to verbalize that. Adults can't. Okay. Now they can if it's like a test or something like that. But if they have separation anxiety, if they have generalized anxiety, social anxiety, they're probably not going to be able to tell you why they're anxious. Okay. And the other thing to realize is that for kids, one of the most present symptoms of anxiety is irritability. So you're often going to see that panic manifest as lashing out at parents, lashing out at friends, and being a little bit explosive. Okay. So that second criterion, then they might suddenly appear frightened or upset without explanation, often confusing behavior to onlookers because we characterize that behavior with anger. Like, oh, you're lashing out at me. What are you angry about? When in reality, it is a result of their anxiety. Children might explain their symptoms as responses and really not be able to verbalize that intense fear or anxiety that they're experiencing. Okay. All right. Sometimes adolescents are better at describing what they experience. Frankly, I'm going away from this thought a little bit. I just think adolescents are better able to use the words we want to hear. They're better able to say, yes, I felt anxious. And then they can't really follow that up with any sort of insight or real understanding of what caused the anxiety or what the anxiety feels like in their body. Okay. All right.
Great. I think this is our last slide.
That's fantastic.
Yes, it is. Okay.
We're right on time.
We are. Look at us.
Woohoo!
Yep.
To do for parents, that first one is what we said before, address your own anxiety. We already know everybody has anxiety. There's no shame in that. The real goal is just to address it. And all the research says that that's the key. Your kids, if you have anxiety, even if you would characterize yourself as having severe anxiety, that doesn't have to impact your kiddo. The X factor there is if you're getting treatment, it won't. They might feel it, but they'll also have observed you using coping skills and they'll be able to use those coping skills as well. Leverage moments of success when you see them really tackle something that caused anxiety and you see that small step towards making a change. Maybe it's even that they say, I'll go talk to somebody. Really reinforce that and just appreciate the heck out of them making that small step forward, whatever it is. Okay. Be honest about how you and the house might be enabling your kids' anxiety. Are there adjustments that you've made along the way to accommodate their anxiety that you really haven't even reflected on? Have you stopped doing things because it just causes anxiety for your kid, right? Things that you might really enjoy doing. Because long term, the goal is for your kiddo to be able to address their anxiety regardless of what's going on and to experience that anxiety and then be able to use their skills to come back to sort of an even keel. Please find a provider and a professional that you trust. Please do that. If you wanted a recommendation, Erin and I could absolutely give you people to reach out to. The most important thing is that your kid and you feel a connection to the provider. Okay, that's really important. Have all open and honest conversations with the school to see how you can collaborate. I remember that last year, not every parent was from Marburn. And I know that there are highly educated folks working at Marburn and providing support to parents. I just want to say, I know a lot of parents at other schools who don't feel that level of support, and I do understand that. So I do say have open and honest conversations if you feel like it's safe. Like if you feel like it's something that the school can support you in, absolutely, please do that. Because most schools really do just want to jump in and help kids. And if you feel like they have the skills and the resources to do that, and your kid are willing to have those conversations, that's important. And then find someone who can support you, parents. Somebody, maybe it's your partner, maybe it's your spouse, whatever the case may be, maybe it's a parent. Find somebody who is able to jump in and support you in those really hard times, because you supporting your kid doing something that they feel anxious about is not easy, right? That feels like us absorbing their pain, us absorbing their anxiety, and really being uncertain, like, is this the right thing? Is it not the right thing? But have some trust in the process that you're moving them towards getting better, and find somebody that you can really process those feelings with, because that's equally important, critically important, right? I had a parent in my office the other day, and we're really working on perfectionism with her little Tyke. He's 4. He won't try things on his own. And as soon as he struggles, she jumps in and helps him. And she loves him so much. She really does. And just trying to support her through letting him struggle a little bit. And those feelings of love and wanting to support don't go away just because your kid gets older. I mean, I'm certain, I don't have a 30-year-old, but I'm certain I'll feel the same way when my kids are 30, 40, right? So those feelings don't go away, and having somebody that you can process with and talk to about it is really important. So
I think that's a good note to end on, and it's 7:45.
Oh
So
my
there's
goodness.
Stephanie. Look at us.
yay! Look at us.
Thank you so very much. And I want to thank you both for your candor in this conversation, the real life examples. I mean, I was laughing a couple times over here, so I really appreciate that. And I hope everyone else on the call does as well. Always such a pleasure. And how multi-layered anxiety is,
Yeah.
and all supports that are available as well. So thank you again. I cannot thank you enough.
Thank you,
And
actually, Stephanie. Thank you. Yeah.
absolutely. Please don't hesitate to reach out to the speakers if you have questions after this, or to Marber and myself. Happy to help support you in your journey to help support your child. Yeah, thank you, Robert. So we are going to end the webinar now, and when it ends, there will be a quick survey that will pop up. Just give us a little bit of feedback. We would appreciate it, and hope you all have a great evening. Thanks again.
Thank you.
Bye-bye.